with you.
I can see my screen.
Yes, we can see it.
Okay, you tell me when you're ready, when you want me to start.
Okay, thank you so much, ma'am. Good evening, everyone. I believe we've had a nice day. The first and second presenter made their excuses and apologized, but since Dr. Florence Briggs is ready, she will be starting today's class, and then maybe we take any other person that is ready. Dr. Briggs, I think your number is 120 something or 130. I can't remember.
No, 033395353. 33395353.
No, I mean the question that you are taking.
Oh, I'm so sorry. Okay, I'm supposed to take 131 to 140, but I can actually take the 130 to 140 because it's they're all alike.
Okay, let me check. We're supposed to take 130. I think that's Dr. Precious. No, is that Dr. Ajayi or Dr. Precious? Let me check. Maybe some of the people that have given excuses already that they won't be able to come. Okay, is Dr. Precious Jean? I don't know whether she's online yet. Yes, we can put 130 to 140. But before you start, ma, Dr. Ajayi Adebayo, please, are you online?
Yes, madam, live and clear.
Hey, Chief Adebayo. How was your data?
Fine, thank you.
Okay. Dr. Yebuze is not on ground. Dr. Prince is not on ground. So, Dr. Briggs, please, let's start with 111 to 120 since Dr. Ajayi is on ground. Then we go to you. Is that okay with you, please?
All right, no problem. Thank you. No problem. That's fine.
Thank you so much. Since Dr. Adebayo is here. Dr. Ajayi, over to you, sir. Thank you.
Okay. So my question starts from 111. I'm trying to. Okay. So the question says, for each of the clinical scenarios, match the most likely computed
No, go and check.
Sorry?
Good evening, everybody.
Hello, may I proceed or any particular issue?
No particular you. Please continue. Dr. Poppy, please, can you make me co-host so that I can meet some people? You're welcome, Dr. Uzoke.
Okay.
Thank you very much.
So for each clinical scenario, match the most likely computed tomogram in figure 1.26. So the question one from where I'm to start from says, a 21-year-old man with recurrent syncope. Okay, actually 110 is not mine, but it's just part of, but let me just stick to what I've been assigned. So 112, a 69-year-old woman with recent myocardial infarction and subsequent stroke. 113 says a 71-year-old man with jugular venous distension, ascites, and marked peripheral edema. So perhaps we could look at the figure 1.26, I think they said. Yeah, figure 1.26. So that, please, could we just move to figure 1.26 so that we'll match the the CT findings to the clinical scenarios. So,
is this a picture?
yes,
Am I
no,
on the right one?
no, ma,
Okay.
it's not this.
Okay. This one. This, right?
It's not this. 1.26. Yes, this is it. This is it. So, yeah. So if you look at the one labeled A, if we look at the one labeled A, because they are A, B, C, D. So we find out that this is a CT, is a cardiac CT, and we see arrows pointing at a a a whitish what I would probably call in CT they call it a hyper, well, I'll say hyperdense, yeah, a hyperdense area that encircles the heart but appears thicker at, it appears particularly thicker at say 1 and 2 o'clock where the arrow is. So that's what I can appreciate in that one. Then the B part, we see also a CT of the heart, and we see on they are labeled, you can see they are labeled RA right atrium, RV right ventricle, and of course adjacent to the right ventricle will be the left ventricle. So we see that for that right ventricle, it appears enlarged, and there are areas of there are hyperdense areas with what looks like undulations where the arrows pointed to. That is what I can appreciate in that particular frame. Please, could we possibly move to C and D? Okay, thank you so much. So for C, we also see the left ventricle is clearly displayed, and we see where the two arrows are pointed at the apex of the heart. We see a mass there that has a different intensity to the other parts of the surrounding cardiac muscle, cardiac tissue rather. And then lastly, on the D frame, we also see the left atrium, there are arrows pointing there, and we see an ovoid, well circumscribed mass with a different density from the other cardiac tissues. So having those as a baseline, we can now look at the scenarios and see what it holds for us. Thank you so much. So, okay, so 111, a 21-year-old man with recurrent syncope. The picture of the scenario of a 21-year-old man with recurrent syncope would not match the A frame. The A frame, you remember, had thickened pericardium. The B frame was that of a right ventricle that appeared dilated and is in keeping with a arrhythmogenic right ventricular cardiomyopathy. And if we look at the age of the patient in question, we know that this tends to manifest in the younger age group. So We know that the, excuse me, the C frame showed us an apical mass, which is in keeping with an apical left ventricular thrombus. It doesn't fit this scenario, doesn't fit the age, and the last is an atrial mass. This also does not fit it. So for figure 111, what matches it most correctly is the B frame, which is consistent with an arrhythmogenic right ventricular cardiomyopathy. So that's my take on that. The picture has vanished though. Is it just my network acting up again? Can the others see the projected picture, the projected book?
No, it's across board.
Okay, I needed to be sure because my network is notorious. So maybe it's network from that end. So
Yes, I think it's Dr. Briggs' network. I don't know if any other person can share for us because she's not yet back online. Please, can any other person share? Thank you. Dr. Precious Ma.
Thank you, Chief Sawa.
Chief Sawa, okay.
Thank you so very much. Yeah, so let's go to question 112. So, brilliant, thank you. So, question 112 says, a 69-year-old woman with recent myocardial infarction and subsequent stroke. So, if we look at those 4 frames, which one would fit the scenario? A 69-year-old woman with recent MI and subsequent stroke. We know the A is pericardial disease. The B is arrhythmogenic right ventricular. The C appears to be an apical thrombus. And the D is a mass in the atrium attached to the interatrial septum. So this 112 would look like a patient who had myocardial infarction. And of course, because of the reduced contractility from the myocardial necrosis, it gives room for thrombus formation. And of course, the thrombus gets ejected into the systemic circulation and the patient suffers a stroke. So that ties it up for 112. Then when I don't mind, I hope you don't mind that I finish this cluster of questions before we can discuss it if there are any contributions. Then 113, a 71-year-old man with jugular venous distension, ascites, and marked peripheral edema. So, of course, we know that in the context of elevated JVP with ascites and peripheral edema, we're looking at a lesion on the right side of the heart. The B frame will not give us that. The C frame will not give us that. Raised JVP and all that with the, so it's more consistent with the A. In the A, we know that the pericardium here appears thickened. The pericardium appears thickened. So this patient is having right ventricular impairment, either in the form of a constrictive pericarditis or even a cardiac tamponade, even though, although we don't have enough information to arrive at that exactly. Thank you so much. Well, we can see the thin layer of the pericardium and how it thickens towards 1 and 2 o'clock. So that appears to be more in keeping with, I think that's figure question 113 that has been resolved. So let's go and see what question 1, okay, it's just 111 to 113 that I'm supposed to answer there. Okay, so do we have any what's our take? Any contributions, comments, critique of this? Because I think this one actually, once we are able to identify what is in the pictures, then tying up the clinical scenario isn't so difficult.
Hello.
Yes, please, sir.
Yeah, just a little
Chief.
contribution. The figure A, apart from the thickening of the pericardium, see the very bright white shadow around there. So that is pericardial calcification, and it's extensive over the right ventricle. So this one is actually a constrictive pericarditis.
Okay, okay. Yes, yes, I do agree with that. Because you can also see that on the left side, it also extends to the left side, but it's not as continuous and as severe as it manifests right.
Exactly, exactly.
Yes, thank you. Okay, so any further contributions? If not, then we fire on to 114. Please, Sarah, could we move to 114? Okay, excellent. Thank you, sir. So it says for each condition, match the appropriate pattern of left ventricular filling as recorded by Doppler of diastolic mitral flow velocities. E wave, early diastolic filling, A wave, period of atrial contraction. Normal left ventricular deceleration time in early diastole is greater than 190 milliseconds. Okay, so we have a scenario of a case where there is E wave greater than A wave, left ventricular deceleration time greater than 190 milliseconds. Okay, then we're supposed to match this with there are some other clinical scenarios that have been painted. Maybe we should take a look at it. Although from our knowledge of diastolic function, it shouldn't be too difficult to figure it out. Maybe we should, yeah, thank you. We'll just go down slightly, then we'll see what options. Beautiful, this is it. Thank you, sir. So we see that the options available are just 4 clinical conditions: restrictive cardiomyopathy, normal pattern, that is normal pattern of diastolic function, pseudo-normalized pattern, and impaired left ventricular diastolic relaxation. So those are the 4 scenarios, and they want us to match the options that I started reading earlier with which one is appropriate. So if we have a patient who has E wave greater than A wave, which is what we expect normally, who has a left ventricular deceleration time greater than 190 milliseconds, and they've been kind enough to tell us that normal left ventricular deceleration time in early diastole is greater than 190 milliseconds, then you will agree with me that that appears to be a normal diastolic function for that patient. So it means that, okay, restrictive cardiomyopathy. So now the issue is which one matches restrictive cardiomyopathy. So in restrictive cardiomyopathy, what we should know is that there is usually increased, there's usually the E wave is markedly elevated when compared with the A wave. So the E wave is multiple times of what you will have of the A wave. The A wave tends to be rather rudimentary in that context. So, and of course, this is because of the, the E wave is due to that's the one that is due to the early passive feeling. So, but in this context, it is markedly elevated because there is a markedly elevated left atrial pressure that would make the E wave ultimately significantly greater than the A wave. So if we have that as our background, if we look at the option D, where it says that, yeah, E wave is markedly greater than A wave, a left ventricular deceleration time less than 150 milliseconds. This is actually consistent with a diagnosis of restrictive cardiomyopathy. E wave markedly greater than A wave, the reason being to the pressure changes that has taken place in the left atrium, and that gives that condition, because the net effect of all that is to have an E wave profile that is markedly elevated compared with the A wave, and to shorten the deceleration time to less than 150 milliseconds. So the question 115, normal, this was the one I had earlier on answered, that we have a situation where the E wave is greater than the A wave and the deceleration time is greater than 190. We had already been told that normal deceleration time is greater than 190. So that's that. Then which one matches pseudo-normalized pattern? Pseudo-normalized pattern. So let's look at the sentences again, which matches pseudo-normalized. So the one that would match the pseudo-normalized pattern, well, of course, we know that pseudo-normalized pattern by the classification, like that's grade 2 diastolic dysfunction, and it is a more severe form than the grade 1, which is the impaired relaxation. So in this situation, we have E wave greater than A wave, because in pseudo normalization, we'll also tend to see an E wave that is greater than A wave. And then the deceleration time will be less than, pseudo normal. It looks falsely normal. So most of all the parameters are similar to what we see in the normal. However, the deceleration time is shorter than 190. The deceleration time for normal diastolic function is greater than 190, but in pseudo, it is less than 190. Then the other option that is also there is we've done restrictive, we've done normal, we've done pseudo. So impaired relaxation. And of course, the only option that we have not made use there is option C, in which in impaired relaxation, which is the grade 1 diastolic dysfunction, we know that there is a situation in which the E wave is smaller. The amplitude of the E wave is smaller than that of the A wave, so that you have an A wave. There's a reversal so that the A wave is bigger, the E wave is smaller, and the left ventricular deceleration time will be greater than 200 milliseconds. So in that order, it will then be D, option D matches restrictive cardiomyopathy. Option A matches the normal pattern. Option pseudo-normal is going to be option B. And then lastly, impaired relaxation will be option C. So those are the matching done for that. Questions, comments? Okay. If there are none, then I will still forge ahead to question 118. Okay. And in question 118, it says, for each of the chest radiographs shown in figure 1.27, match the most appropriate cardiac diagnosis. So we have 4 chest radiographs that have been shown in figure 1.27. Not this. Excellent. This is it. Thank you so much, sir. Thank you so very much. So let us put heads together and look at these pictures and see what are the apparent abnormalities there. So if we look at the one labeled A, we see a chest radiograph that shows prominent pulmonary vascular markings. Yes, I think the pulmonary vascular markings are actually prominent. But what is most striking there is that, one, there is a bulge in the area of the left atrium. That's about 3 o'clock on picture A. And then we also note that there does seem to be some dilatation of the right ventricle. You know, the right ventricle is that bulge on the that parasternal, exactly. Yes, exactly. That curvature, that is where the right, beautiful. Thank you so much. That is ventricle is. So you can see it's bulging beyond the outline of the spine. You see the vertical bony spine. You can see that that bulge that shouldn't be, that's not the normal outline. So this picture is typical of a condition like mitral stenosis. It is said that in mitral stenosis, usually the left atrium is enlarged. We have pulmonary vascular markings, and of course, it depends on the severity anyway, but usually the heart size, especially in the early stages, is not usually dilated at that stage. So those are the prominent things on that film. If we go to the B film, we see that unlike the A film, you don't see that bulge indicative of a dilated atrium. The normal cardiac contour is actually lost. If you look at this film well, there is a bulging also of the right ventricle towards the right side. There is loss of the normal cardiac contour. It's so smooth. If you compare the outline with that of the previous one. You see that, yes, you see that the outline is so very smooth. And this pattern is said to be flask-like, and it's typical of pericardial effusion, you know, the water bottle heart picture. That's typical of it. We also note that we do not see the
Dr. Ajayi?
Yes, please. Yes, please. Am I? You want to correct me or say something, man?
Yes, sir. I
Dr.
was saying,
Andrew?
yes, I was
Hello?
saying that I can't hear you clearly. Am I the only one?
Ah,
It's
hello.
a network, man.
Okay, thank you so much. Thank you.
Dr. Adeyanju is your village people. I told you.
Our village people are very nice. So,
Ah, thank you. Sorry for the
so
interruption.
No problem.
no
It's
problem,
clear.
man. Okay, man. Thank you
Well
so
done,
much.
Dr. Ajayi.
So,
I appreciate you, sir.
thank you, my chief. Thank you so much, sir. Grateful. So, we find out that we do not see any prominence of the pulmonary vascular markings, and the well-rounded and smooth. So this is a finding in pericardial effusion. So the next one, the picture C, shows us what, but you find out that yes, sorry, don't let me go into that. Let me just talk about what is prominence of the aortic knuckle. Find out that below the aortic knuckle and going towards the curved margin of, yes, you find out that that opacification that seems to run from the lower part of the aortic knuckle to out there, that is actually a dilatation. You find that this appearance is typical of, yes, exactly. Thank you so much. That is aorta. That's a dilated aorta. We also see that towards the right, there is also bulge of the right ventricle, a well-rounded cardiac apex, almost as if it's even like almost like a boot, although it's still different from, a bit different from what we see in tetralogy of Fallot, where we see the boot-shaped heart. Yes, well-rounded, and even as if it wants to lift up. So this kind of a picture tells us that this kind of a picture is typically found in aortic regurgitation, prominent aortic knuckle, dilated ascending aorta. Because of the pressure changes, there will be some degree of ventricular hypertrophy here. And so the last one would be this other picture, the picture D. And the picture D has, initially, if you look at it, it has some similarity to the first frame, the A. However, you notice that there is more prominence of the vascular markings. You notice that it also has dilated left atrium and also has a bulge of the right ventricle towards the right. But you notice that the prominence of the pulmonary vascular markings is much more than that of all the others. And this, yes, it's so prominent. So this picture is typical of atrial septal defects. So what we just need to do is to know the key findings for some pathologic states and then look for key findings in the chest radiograph and help to construct a diagnosis. I don't know if you remember Chief Okopi. Is Chief Okopi online?
Yes, Chief.
Because
your boy is lawyer.
Okopi, sir, do you remember
Yes, sir.
do you remember the radiograph we were shown during the general medicine?
Yes,
The radiograph we were shown exactly that radiograph.
Yes, sir.
The first radiograph we were shown, it had, a dilated heart. It had bulging of the left atrium was obviously also enlarged with prominent pulmonary vascular markings. Just to emphasize that we should pay attention to these features, these radiograph features, because they may also bring them. They could even come out in MCQ, because after all, other colors do come out, other pictures do come out in MCQ. So having said that,
hello, Dr. Ajayi.
Yes.
Dr. Kweki, please, can you make some other persons co-host so that we can mute those that enter the class unknown so that we can have silence?
Yes, sir.
All right, go ahead, sir. Okori Leonard, his mic has been on 247.
Okay, sir.
So, all right, good. Yes.
Okay. So if we look at which one of these four frames will match mitral stenosis, so we find out that the A frame we said had features that are typical in mitral stenosis. There's a mitral valve pathology, and yes, A frame.
What
is the one I'm saying?
Hello, Ajayi.
Like
sorry, please. Hello, Dr. Ajayi. Is Dr. Kweki, are you there, please? Maybe Kweki is not with his device. You should make some other persons co-host so that we can mute people coming in there, distracting the class. Kweki, are you around? Kweki. Hey. All right. Just go ahead. Let's see. Catherine, please, can you mute your device? Catherine.
Once they are close to God, these things are not hard.
I'm telling you, once you are close, once you are close to God, God makes everything work.
Now.
I'm telling you.
And cancel the one
that are not supposed to be there. God
cancel.
Hey, now wow.
Anyhow and get good. You cannot do anyhow and get good.
Can they call Kweki on his phone and talk to him?
Yes.
I think you don't know the. Yeah, I don't know, sir.
This one doesn't.
God, I don't.
Where are we going to leak Stone Cold Ice? Who heard the preaching about Stone Cold Ice? You heard it, but hey, Rema. I'm pizza, high five! Oh God, this one was not sleeping. You mean it? You heard it, sir? Good evening, sir.
Yes, sir.
Oh.
Okay, let's go.
Chilabelu heard it. Oh my goodness.
Okay. Thank goodness. I'm sure that wasn't deliberately done, but we just have to be more attentive with our devices. Sorry for the break in transmission. May I proceed?
Please go ahead. She said you should be close to God. All these things are not hard.
Pastor Copy. Okay, sir. So if we look at yes, sorry. Yeah, sorry. It's not deliberate, we know. So the option, which one is in keeping with mitral stenosis? So if we look at option A, as I had said earlier, option A, you see the dilated left atrium, you see the prominence of the vascular markings, you see the dilatation of the right ventricle, which happens in the context of when pulmonary hypertension sets in. So the option A is typical of what we can find in mitral stenosis. And therefore, I will match the option for mitral stenosis against option A. What's the question after mitral stenosis? Which let's look. Sorry, please, sir. Could we, Chief Sawa, can we move down exactly? Let's go down a bit more towards the issue of. I think that will be question 119 or so. Yes, keep going. Okay, good. This is it. So aortic regurgitation. So which one would match aortic regurgitation? So if we go up again to the pictures, we see that option B, we said matches pericardial disease, and option C, the reason why this is typical of aortic regurgitation is, as I said, there is a prominence of the aortic knuckle. We also find that the enlargement of the left ventricle is typical. Would result in left ventricular dilatation and displacement. Then, because in aortic regurg, the pressure volume changes, gives room for dilatation, unlike what we see in aortic stenosis, where it may not be marked by such dilatation. So the abnormalities in the ascending aorta, the prominence of the aortic knuckle, the dilatation of the left ventricle, this can pass for a chest radiograph of a patient with aortic valve regurgitation. I do not see any other thing there. Then after aortic regurgitation, the next is atrial septal defect. Okay. So for atrial septal defect, we said, of course, we know that in atrial septal defect, what usually happens is that there is a defect through which usually there is a left to right shunt because the pressure on the left side exceeds that of the right. So in atrial septal defect, the picture, the D picture, matches that. The dilatation of the atria, the dilatation of the ventricle, the marked pulmonary vascular markings. These are all typical of especially that's, it could even, you could easily say that the atrial septal defect is almost looking like that of the mitral stenosis, because in severe, advanced mitral stenosis, they may look like that. So I don't know how you would actually differentiate probably other findings between mitral stenosis and that of a patient with atrial septal defect. But the D frame matches that of a patient with atrial septal defects. What is the next question? Okay, so that one now says pericardial effusion, and that's the simplest of them all because we spoke of the B frame where we saw this loss of the cardiac contour, obscuration of the pulmonary vessels, you know, and then the the B frame. We can see the water bottle appearance, you know, everything is so smooth, so rounded. So with the loss of the pulmonary vascular, the pulmonary vessels that we normally see at by the hilar. So with that, I think we have successfully matched the questions. That's 121. Okay. So yes, I think so. Question 122.
Dr. Ajayi. Hi.
Yes, please.
Good evening.
Good evening, ma.
Thank you.
Oh, okay. I wanted to start encroaching.
I know. I would have let you, but you know, I have to present.
Yes, thank you
so much for that excellent presentation.
So hello.
Yes, please, Chief Conte.
Yes, just some small comments on the X-ray, on the X-rays that you've discussed. For the mitral stenosis, one of the key things that you should remember in the chest X-ray is that when you have pure mitral stenosis, apart from the left atrial enlargement, the left ventricular size is usually normal. So you can only get enlargement of the left ventricle in patients who have a mixed mitral valve lesion. So you have both stenosis and regurgitation. But once it's pure stenosis, your left ventricle is always normal in size. You don't get left ventricular enlargement. That's one key thing that you should remember. Then looking at the atrial septal defect. So you are mentioning that, you tend to see filling of the pulmonary bay. It almost looks like there is right atrial enlargement. But in atrial septal defect, that is actually not right atrial enlargement. It's actually dilatation of the pulmonary vessel that fills up the pulmonary bay in patients with atrial septal defects. So that's one key thing that you need to differentiate between that. So usually when you have left atrial enlargement, it's like you just have straightening of the left atrial border. Whereas when the pulmonary vessels are dilated, you actually see bulging at that pulmonary bay because of the dilatation of the pulmonary vessel. And then lastly, for the aortic regurgitation, like you mentioned, the dilatation of the aortic root is very important. But the compensatory mechanism that you get when you have the volume overload of aortic regurgitation is eccentric left ventricular hypertrophy. So you see a predominant enlargement of the left ventricle when you have aortic regurgitation, as you see in the picture. So that is because of the eccentric left ventricular hypertrophy that you get with that. Okay, I think that's it. We can move forward.
Thank you so very much, Chief Conte. Thank you so much. But this picture, the D frame, the D picture, this thing appears enlarged now. The right atrium in this picture, the right atrium appears enlarged because with increased flow in ASD, with increased flow, from left to right shunt, I would expect that there would be increased flow, also to the right ventricle from where it is then, sent up into the pulmonary trunk. So to me, I don't know, maybe I was wrong, but were you saying that the right the right border of the heart here is not enlarged?
So yeah, so what you can see on the AP chest X-ray, you'll be able to deduce a right ventricular enlargement. But the left atrial enlargement from the AP view is difficult to see. So you usually do a lateral view, and then you assess the distance from the sternum to the right atrial border, and then you see the filling of that area. But on a chest X-ray PA view, seeing the right atrium is difficult. You can't comment on the size of the right atrium from a PA view. You have to do a lateral view. Okay, so what I was saying is that the left, when you look at the left, where you expect left atrial enlargement, it's filled, the pulmonary base filled the same way that you're seeing in the figure A for left atrial enlargement. But the difference is that in figure A, there is actually left atrial enlargement, but in figure D, there is no left atrial enlargement. What you're seeing there is dilatation of the pulmonary vessel.
Okay, I get you.
Yeah.
I get you. Thank you so much.
Yeah, good evening, my chiefs. Well done, Dr. Ajayi. Thank you for the presentation. I just wanted to make a contribution regarding the previous question on left ventricular diastolic dysfunction. I hope I'm audible.
Yes, ma,
Hello.
you are very
Okay. All right.
Yeah.
So the E over A and DT, that deceleration time version, which is more commonly used, is the older one. Although this book is new, there's I think 2016 ASE and the European Cardiovascular Imaging joint recommendation for diastolic dysfunction. Is not as popular, not as commonly used, but in the event that it should come out. So it also uses E over A ratio. It uses left atrial volume index, that's the LAVI, uses TR peak velocity, and it downplays the deceleration time. I'll try to find the flow chart or table and put it on the WhatsApp group, but in case we haven't come across it, it exists so that we know. So E over A, E over E prime, LAVI, and TR peak velocity. And it takes also into cognizance the presence of, I think, LV dysfunction and otherwise. Thank you.
Very true. Very true. Thank you so very much, ma. And in fact, did you notice that most of the echoes that we do, we've already been told, the books tell us that the volume measurements are actually more accurate than the linear measurements we do for most of our echoes. But we find out that I guess just because maybe number one, routine, we are used to the linear measurements rather than the volume measurement. So you find out that most of these newer approaches, we are to be embracing them more slowly than, I don't know, that's because I know that even when I still do echo, I still just very, very quickly take all those linear measurements and other, but with practice, one should actually go in line with the new guidelines. Thank you so much.
Sure. The linear measurements are a lot faster. The volumes are cumbersome. If you're doing left atrial volume index, you have to do 4 apical 4-chamber, apical 2-chamber, trace it, and all of that. So it's understandable. Yeah, the fourth component, thank you, Dr. Rimalade, is average E over E prime. So take septal, take lateral, do the average. So it is quite cumbersome, actually. This particular recommendation, but just so we know it's there. Thank you.
Hello, Chief Okopi. Based on your
yeah.
experience in the last exam, have our examiners moved on to these new recommendations, or we are still, or they are still with the old recommendations in terms of diastolic function?
Our examiner has moved on. So what Rukaya is saying, what Ruki is saying is quite impressive and up to date. Going through the exams, you'll find that he has really improved to up-to-date cardiology practice. So I think we should discuss more up-to-date cardiology practice. Yeah.
Fantastic.
Good evening, everyone. Good evening, chiefs. I think I'm the one that is supposed to take 121 to 130. My name is Dr. Enajer. Please, can I kindly share the screen so I do not inconvenience the person who is
sharing? Dr. Sawe, according to Ajayi, Dr. Sawe.
All right, thank you. Thank you.
Ajayi says Dr. Sawe.
All right, give me a minute, please. All right. I'll zoom in. All right. I hope I can zoom in properly with my laptop to where I want. All right. Good evening, everyone. My name is Dr. Enajer, and I'll be taking, thank you, Dr. Ajayi, for taking number 121 for me. I'm grateful, and thank you for your explicit presentation. I just have some points to make about the pericardial effusion question and the chest X-ray findings of pericardial effusion. So there were some signs that are accustomed to that we use for chest X-ray findings of pericardial effusion. And some of those signs are called, one is called, from my research, it was called water bottle sign. And it's in keeping with, let me go back to the chest X-ray. All right, so it's in keeping with this slide.
Is it my network? I'm sorry, please. I'm not hearing.
Can you hear me? Okopi, can you hear me? Dr. Chief Okopi, can you hear me now? Can everybody hear me clearly, please?
I can hear you loud and clear.
So that my voice is slightly soft, but yeah. So, so yeah. So it's called the water bottle sign, and it's the loss of the configuration around the heart that Dr. Ajayi was talking about. So it's like global enlargement of the heart and loss of the cardiac silhouette. So Dr. Ajayi talked about this excellently when he talked about the loss of the cardiac silhouette. So the sign is called the water bottle sign. Then we have other signs also, and we have another sign called the Oreo cookie sign that is seen in the lateral X-ray. So it's like a lucency that is seen in between the retrosternal and epicardial fat, and it's greater than 2 millimeters. Unfortunately, I don't have a picture here. So that is called the Oreo cookie sign also, that can be seen on chest X-ray, but it can only be seen on the lateral chest X-ray. And it has a specificity of about 94%. So there have been some issues, especially Dr. Ajayi also mentioned this about cardiomegaly in heart failure and about cardiomegaly also in pericardial effusion, and now how you can differentiate both in simplified terms. It's not like you cannot see pericardial effusion and heart failure in one chest X-ray, but if you're looking for specifically just pericardial effusion, as he said, you'll not be able to see the hilar vascular congestion that you see in heart failure, like you can't see here. And there's also obliteration of the hilar vessels, and there is no vascular pulmonary congestion also that is seen also in patients that have cardiomegaly also in pericardial effusion. That's some of the things that can help you differentiate a patient that has heart failure with cardiomegaly and a patient that has heart failure from just that has pericardial effusion, although both are not mutually exclusive. So I would like to quickly just go straight to question 122 to 125. So this is 4 questions in one, and I'd like to pick them one by one, but let me read the question first. So match each description below to the most appropriate cardiac rhythm. atrial tachycardia, atrial flutter, sinus rhythm, atrioventricular nodal reentrant tachycardia, and atrial fibrillation. So our numbers of our questions is 122. P waves are negative in lead AVR and upright in lead 1, 2, and AVF. So what would be the best option for this? So looking through our options, obviously we'll look at the answer is going to be sinus rhythm, because for P waves to be negative in your AVR and upright in your 1, 2, and AVF is pointed to sinus rhythm. So what is sinus rhythm? Sinus rhythm is P wave that's positive in 2, 3, and AVF. And this shows that there is a leftward inferior direction of the activation of the SA node. And that's about at 60 degrees, because that's where we know that the direction of lead 2 is. So, and you also see a negative P wave, or a biphasic P wave. You always see an upright P wave or a biphasic P wave also in green one, the cardiac lead. So that will lead to your sinus rhythm. That's your P wave that is negative in AVR because it's going against the direction of activation. So it's going to be negative. Then you have your upright P waves in your 1, 2.
So sorry, please. In my network,
Sir,
hearing
your
her
network.
clearly. My network.
Your network.
Okay.
I think so.
Okay.
Can everybody else hear me clearly, please? So it's not my own network, because my network is bad today.
Yeah, we can hear you clearly.
Oh, okay. All right, thank you. So I'll be moving down to 1, 2, 3. So the question for 1, 2, 3 is rhythm can be due to automaticity, reentry, and triggered mechanism. We know that these are the 3 mechanisms of arrhythmias, which I have fondly named RAT. So R is for reentry, A is for automaticity, and T is for triggered activity. So when you look at the options, you're looking for an option here that has these 3 mechanisms of arrhythmia. Obviously, sinus rhythm is not one of them. So we're looking at the other 4: atrial tachycardia, atrial flutter, atrial nodal reentrant tachycardia, and atrial fibrillation. So we all know that atrial flutter most times is a reentrant arrhythmia. Most commonly is a reentrant arrhythmia. We also know that AV-NRT also is a reentrant and atrial fibrillation. But let's come back to atrial tachycardia. So atrial tachycardia is like multiple focus of arrhythmia or irritable cells in the atrium. So atrial tachycardia can come from automaticity of the atrial cells. It can also be a reentrant form of tachycardia, because there are many forms of atrial tachycardia, and it can also come from triggered mechanisms. So the only option here that shows these 3 mechanisms of arrhythmia, that different types of mechanisms of arrhythmia can cause that arrhythmia, is A. Then we'll go to 1, 2, 4. We talk about a micro reentrant mechanism in the right atrium. So we're going to be talking about, obviously, the atrial flutter. Atrial flutter, we know, is a cavo-tricuspid isthmus dependent arrhythmia. And it's usually at a rate of 250 to 350 beats per minute, and is either typical or atypical. The typical, we have a clockwise kind of P waves in your negative leads. So that's a micro reentrant mechanism. It has a micro reentrant mechanism around your right atrium. So atrial flutter is our option for 1, 2, 4. So we're going to go down now to 1, 2, 5. The initial P wave of this tachycardia is usually different from subsequent P wave. So this calls to question, what kind of arrhythmia starts with? Because if the initial P wave is different from the subsequent P wave, means that there's something that triggered it at the beginning. So that means there's most likely an ectopic beat that comes before, most likely an atrial ectopic that comes before, that triggers this arrhythmia, most likely before the tachycardia. And the kind of arrhythmia here that fills this criteria, because we know that atrial flutter, we know how it starts, we know what atrial fibrillation is, we know how atrial tachycardia is, that can come from 3 different mechanisms. We can have MAT, and all other things. We can have focal atrial tachycardia, we can have multiple multifocal atrial tachycardia. But let's look at AVNRT properly. So AVNRT is a reentrant tachycardia, which usually takes place around the AV node or in the AV node. And we all know that the AV node is located in the triangle of Koch, that's surrounded by the coronary sinus, the septal leaflet of the tricuspid valve, and the tendon of Tadl. So the septal leaflet of the tricuspid valve has the fast pathway, and most likely the coronary sinus, that's where the slow pathway is. And we know that we need at least two of these different pathways to be able to make a reentrant mechanism. So when we have an ectopic beat, which is the start of this type of arrhythmia, the initial P wave is always abnormal. It's different from what follows after that. So what follows after that, you can have an AVNRT, which we know that we can have P waves, which are retrograde, which are after your QRS complex. So the only arrhythmia here that is a likely option for this initial P wave of the tachycardia is usually different because of that ectopic beat is your AVNRT. So with this explanation, I'm waiting for comments, contributions to this complex arrhythmia question. Thank you, everyone.
Am I going to do? Continue with this.
Comments? Who is this? Comments, anyone, please?
Yes, thank you, Dr. Precious, for that very lucid explanation. It's quite complex, I agree with you, but you've given us so much to chew, and it's quite appreciative. So it's just to mention also that for these automaticity, reentrance, and triggered mechanism, you can also see that for ventricular tachycardias. So we should note in case the questions are framed another way. So we can also see that in ventricular tachycardias. Then for the AV nodal reentrant and tachycardia, there are two types for that. We have the typical and the atypical. The typical will be the ones that go through the as in retrograde and anterograde. So the one that will pass through that is slow fast. So it's passing through the nodal, or the ones that is not passing through the nodal distance. So in case they ask it in another way around, that it's possible for that not to pass through the nodal, and it might not be automatically reentrant or triggered. I don't know if I'm making sense.
Yeah,
but
I know what you're talking about. The slow fast, fast slow.
Yes, exactly. So in case they now
have
another way, we'll be able to understand that it's not really pathognomonic the way we have said it now. That it could also be a false depending on how they frame it. And for the automaticity for the atrial tachycardia, in case it's ventricular tachycardia we see there, it can also be true. Thank you.
Thank you so much, Dr. Orimolade. So yes, in automaticity, ventricular tachycardia is also one of the options in automaticity, and also there are many things underneath automaticity. So thank you, Dr. Orimolade. I'm very grateful. Do we have any more clarifications, questions, or contributions to this topic? Because it's quite a big topic. Anyone? All right. Going once, going twice. One. All right. So we're going to go to questions 126 to 129. So this is another complex question on which we're starting. Hi. Please go ahead. Chief.
So I want to make an inquiry again.
Okay, sir.
Dr. Orimolade said something that slow, fast pathway can be outside the node. That the fast pathway is in the node, slow pathway is somewhere else. I don't know if I'm audible.
Yeah, audible, sir.
Audible, sir.
Yeah, I just needed to get that point again that you are trying to make.
Okay, I was trying to make a point, because this is just like a fixed question that we are seeing in case it is framed in another way, so that we all don't think that automaticity, re-entry, and triggered is strictly for atrial tachycardia. and that not for us not to think that the one that starts with an abnormal initial P wave followed by tachycardia of different P morphology is strictly for AVNRT. That was what I was trying to say, because it's possible to have a VT in case they put another option there and it's ventricular tachycardia, for instance. Now, we would reason it out that automaticity could also go for it. Then also for the AV nodal reentrant tachycardia and the AV reentrant tachycardias, we have the typical and the atypical. For instance, for the AV reentrant tachycardia now, we have the antidromic and the orthodromic. The antidromic will go through the accessory pathway. The orthodromic will go through the nodal pathway. While for the AV nodal reentrant tachycardia, we also have the typical and the atypical. That's what I was trying to just explain, that is not dogmatic as this question frames it, in case we now see VT or AVNRT or AVRT in options to match, Chief.
So now in the AVNRT, that's what was specific about. As in, what do you clarify as the typical and atypical? Is there anything outside the node from, because you mentioned something outside the node for typical and atypical?
Okay, for it, if I remember correctly, sir, for typical AVNRT, we have most times, in fact, for all, let me say AVNRT is usually around the nodes, the AV node, as the case may be. So we have, it must pass through the node before going out, and depending on if the the fast track is through the node or the slow track is through the node. So for the typical, the slow track should be within the node, and for the atypical, the fast track will be in the node.
What are you trying to really say? Can you come again, please? It seems you're mixing things.
Jesus. Okay, sir. In AVNRT, we have the typical and the atypical. Usually, we have the fast and the slow, which we go around the nodes, around the AV node. So it's possible to have the transport of the fast, is either through the fast track or the slow track. I don't know if I'm making sense, but is either the impulse or the action potential, yes, is generated through the fast track or the slow track. So if there is a generation through the fast track, for instance, that means the slow track to be retrograde. But if it's the other way around, it will be anterograde. So that's the typical and the atypical, sir.
Sir, can I help out with this question?
Yes, maybe you should.
Okay, so there is typical and there is atypical. So the typical AVNRT is usually how it is seen on ECG is that is a retrograde P wave that is related to the QRS complex. Most times it's a retrograde P wave to the QRS complex. And there's an RP to PR interval that is used to know which one is atypical or which one is typical. So typically in the typical AVNRT, your PR, your RP, that's your RP interval, is normally less than your PR. I don't know if I can repeat that again. So your RP is normally less than your PR, and that is less than 1. So that's how it is graded according to the ESC guideline. So this is caused by a long PR interval as compared to your atypical, in which your RP is greater than your PR, and that is greater than 1. So your typical is normally a slow, fast pathway. Meanwhile, your atypical is a fast, slow pathway. I think that's what you're trying to say, Dr. Maladi.
Yes, thank you.
Yeah, so I think that is, those are the differences. Then on ECG, for your typical, you can find other ECG criteria that can include a pseudo R wave deflection in your lead V1, a pseudo S wave in your inferior lead, a notch in your lead. I don't know if I can remember, in your niche AVL, and a pseudo R wave also in your AVR. That's for your typical. Yeah. I know it's a lot. I'm sorry.
It's a lot, actually.
It's a lot. It's a lot. Sorry, sir. Sir? Sir?
Okay, oh, so one important thing, Dr. Imolade, is that I know you're talking about typical or atypical. Both fibers are in the AV node, okay? Everything is hovering around the AV node.
Yes.
Right?
Yes.
So it's not one fiber is far away from the AV node, another fiber is in the AV node. AV node is generating something, then the other one is interrogating it. No.
Those ones are in the AV node. The ones that are outside the AV node I was talking about, the AVRT, sir, that goes through the accessory pathway. And that one too has retrograde and anterograde. That's autodromic or antidromic, sir. So I get your point. Thank you. Thank you, Chief.
Thank you, sir.
Someone
thank you.
Thank you. No, Chief of copy.
Sir?
Sir?
Chief, we didn't hear you, sir.
I didn't hear you, sir. Huh?
Lost. We didn't hear you. I think you called my name. Sorry, sir.
Yes, he called your name, but his network went, so we didn't hear what he said last.
No, I was just saying that Chief of copy should make sure we present AVRT and AVNRT so that the class will be on the same.
All right.
Thank you.
I will contact one person, maybe Rukaya or Precious, to present it while you help us as a guide, sir. Thank you so much, sir.
Thank you, sir.
So maybe Rukaya or Precious, please, you guys, one of you. Oh, I think Precious appears to be very.
I'll present it. That's fine.
So present AVI.
I'll present AVNRT.
Okay, thank you.
All right, thank you. Thank you, sir.
Even though Prof has done the presentation on it, it's on the Telegram page. I think Kweki is putting them to you. You can actually go through it while you prepare.
All right, thank you. I will. All right, thank you. Thank you, Prof. Thank you, Dr. Okupi. Thank you, Dr. Maladi. Thank you so much for the question.
Yeah, so because you remember.
Hello?
Yes, you remember there was actually a question in the Viva that the clinical scenario they actually painted. And Chief Okopi, you remember now there was a question.
Yeah, the reason why I think when we need to present this, because it's a common question that has been recurring in Viva and also in the MCQ. People can easily confuse it. So when she presents it with the guidance of Prof, it will become clear to everybody. I remember that question, station 5, Abi? Dr. Ajayi?
Absolutely, absolutely.
All right, thank you.
All right, thank you, sirs. All right, thank you, sir. I would get in touch with Prof and get to the slides on the group. Thank you, sir. So I'd like to move on to question 126 and 129. I have some complex questions today. So this question involves your ROC curve, which is on the next page. So the question reads as follows. For the receiver operating curve, that's ROC for the two diagnostic tests as shown in figure 1.28, matching the following: A, 11%, B, 40%, C, 59%, D, 47%, E, test A, F, test B. So 126 reads the false positive rate of test A at a sensitivity of 98%. That's the first. So I would like to go to the, all right. So this is the table. This is the graph for the question. So you have your sensitivity on the x-axis and you have your specificity on the y-axis. So this, I'm going to put up a slide that says this is the same thing as your true positive rate, and your specificity is the same thing as your false positive rate. So once we have that clear, I would like to make some definitions before we move forward about sensitivity and specificity. Before I finish this thing, let me not bite my tongue. So sensitivity, what is the definition of sensitivity? It qualifies as a test's ability to detect a disease. That is the definition of sensitivity. And it's the same thing as your true positive rate. Then for your specificity, it's known as your false positive rate. And it's defined as the ability to rule out a disease. This is going to be very important when we're trying to understand this curve, this ROC curve, and this test A and the test B. So it's important to note also that if a test is highly sensitive, if it is negative, it is unlikely for that disease to be present. I'll repeat. If a test is highly sensitive, if it is negative, it is unlikely for a disease to be present. There's a short form for it. I'll put it on the group. I have SNOT. That's a short form I used to remember what sensitivity means. Then for specificity, if a test is highly specific and the test is positive, it's likely the disease is present. That is why tests that have increased sensitivity are used as for screening tools, and specificity are used, those who are highly specific are used for confirmatory, are used as confirmatory tools. So now that we've gotten the preamble out of the way, I'll go back to the question. So when I say false positive rate now, we all understand that I'm trying to say sensitivity. So let's go back to the question. So false positive rate of 98%. So this is what it is here. And we're looking at it in test A. So we're looking for this so this is the false. So we have a sensitivity here of 98%. So we're looking for the specificity, sorry. So we're looking at here from test A. So we can see it here. When we now go down, we'll now trace it down because this is test A. This is test A, sorry.
Can you zoom? It's a bit small.
Oh, I'm so sorry. Please let me zoom in a bit. Please, is it better now? Please.
Yes, much better.
So this is your sensitivity, right? And this is your specificity. So we're looking for specificity because we're looking for false positive rate. So we trace it here to test A, and we're going to trace it down. So if we're looking at this and we trace it down, it's going to be 40%. So let's check. So the specificity of this test is 40%. So that will be the B option. So we'll go to 127 now. The sensitivity of test A at a specificity of 98%. Let's go back to the table, sorry. So we're going back up here. So this is still test A. So this is about 98%. So we can see here that it's somewhere here. So we're looking at almost 59, 60%. So we'll look for that option here. So we have an option. So C is going to, so it's going to be 59% for the sensitivity of the test. Then we're now looking for the positive predictive value of test A. So positive predictive value is a percentage of patients that, or people that actually have the disease. That's a positive predictive value. So with a sensitivity of about 98% for a population with a disease prevalence of 50 in 1,000. So here I would like to change my slides. Sorry, let me stop sharing because I have a slide that I'm going to use to demonstrate this quickly. So it makes it easier for me. Sorry, let me open my slide. Alrighty, so it is here. All right. I don't know if everybody can see this slide. All right. Please, can everyone see this slide? Yeah.
Yes, we can see.
All right. So we're looking for the question here on positive predictive value. So I'm going to use this slide to explain it because it's a bit complex. So I have to go through this slide. So this is what sensitivity is. This is what it said is 98% in that patient, in that group, in a group of 50, disease prevalence of 50 to 1,000. So the total number of patients affected, if they say it's 50 to 1,000, is 50. So the total number, this is a confusion matrix that I created for that question. So, which is used in ROC curves to create ROC curves, multiple confusion matrices. So total number of patients affected are 50. So therefore, total number of patients unaffected, if we take it away from 1,000, because it's 50 in 1,000, it's going to be 950. This whole part is an addition. So total true positive and false negative, total, when you add them together, make your total number of affected, which is your 50. Meanwhile, your false positive and your true negative, when you add them together, they make up your total number of those unaffected. So let me go to all these definitions. So when you're talking about your TPR, which is your sensitivity, is your true positive over your true positive plus your false negative. That's how we get sensitivity. But in this case, we already know the sensitivity that was given to us in the question was 98%. Then for your specificity, a false positive over false positive plus true negative will give you your specificity. It has not been given yet. This is going to be 60%. But because if you go back to that drawing, to that ROC curve, when you trace 98% in test A, you get 60% as your specificity. So I just inserted it here. So you're now looking for your positive predictive value, which is your true positive over your true positive plus false positive. So let me go back here now. So your true positive are those who have the disease that have been tested and they say, okay, they have the disease, they're 49. These ones are supposed to not have this, but it's a false negative. That means they have the disease, but it was a false negative. This is your false positive. And this is your true negative. So these are the ones that don't actually have the disease at all. So when you're inserting it into your positive predictive value table, you are now looking first for your true positive, because what was given was just your sensitivity, the number of patients that had the disease, and the total number of patients and the unaffected patients. So you want to start from your true positive. That's the number of people that actually have the disease. So this number of people affected, which is your TP, your true positive plus false negative times your sensitivity. When you imagine this table now, you have your sensitivity here already, and you now take this part, you take it to the other side. We are going to be timesing it. So that's what this table just looks like, because you're looking for TP alone. So you get 49. You insert it into this table as 49. Then your false negative, obviously, from the total number that you have here, 50 minus your total population minus your true positive, you get your false negative. That is one. You insert it here. Then you're not going to be looking for your true negative because you need your false positive. Your true negative is the number of unaffected people, which is your FP plus TN, times your specificity. So you're taking this one to the other side because you already have 60%. So you're going to insert that here to be able to get your false positive. That will be 950. That's total number of people unaffected times your specificity, which was 60%. You get 570. They are now looking, based on the fact that you have found your true negative. Now you have inserted it here. You're now looking for your false positive. We now have this, your 950. That's the total number of patients that were affected. That's your true negative to get your false positive minus this 570, and that will make 380. So you have gotten all the indices you need to be able to use for this for your PPV calculation. So when you insert it here, you have your 49/49 plus 380, that's equals to 11%. So this is how you know the percentage of people who actually have the disease. So these are this is percentage of people who actually have the disease. I'm going to pause here for clarifications because this was just me talking. Hello? Anyone? Can I stop sharing? All right. So back to the question. All right. So for your PPV now, that's your positive predictive value. You have 11%, and that's A. So that is how you get that percentage from just the only indexes that were given to you, using the ROC curve to get your specificity and using the prevalence, the disease prevalence, which is 50 to 1,000. So I'll now go to 129. Now the question is the superior screening test, A and B. What is the superior screening test? Remember what I said? I said that when a test has an increased sensitivity, has a better sensitivity, it's a better sensitivity is always a better screening tool, or like a test that has a better specificity, which is a better confirmatory tool. So let's go back to this curve. So let's look at this curve let's look at a sensitivity of 98%. If you look at a sensitivity of 90, because we are looking for screening now, a sensitivity of 98%, we can see that for test B, we can see that the specificity is, if you trace it down here, so we're going to be having something about like 60% here. Then let's compare it. This is A. Then B, let's compare it to test B. So when you take it down here, is everybody following me? You now have about 70%. So from this table, from what we are seeing here now, right, and the options, let me go back to the options. So we're asked that is it A or B? That is a better screening tool. So based on the sensitivity of 98%, there's a higher sensitivity, there's a higher specificity in test B than A. So therefore, it will make test B a superior screening tool to A. Please, I like questions here. Okay, there are no questions. Okay. All right. So B is a better screening tool. Should I go back? Does everybody understand what I'm saying? Okay, there's no response. All right.
Okay, so let me do contribute a bit. So regarding sensitivity and specificity for a particular test, sensitivity and specificity are qualities of the test, you know, but for positive and negative predictive value, they depend on the population being studied. That is why they gave us the prevalence of the disease in this particular population. So there are tests that would be good in a population that has high prevalence of the disease. based on their positive and negative predictive values versus populations that have low prevalence of the disease. So let's look at when we talk about doing D-dimer test in pulmonary embolism, we say it has high negative predictive value because we select the population that we use it for. So if it's negative, then they most likely do not have the disease. So ROC curves they're very annoying, but then they're necessary, and like is illustrated on this particular sample. Sensitivity was plotted on the y-axis and 1 minus specificity on the y-axis, and we have two tests being compared. Another way to use ROC curves is to plot one test on the y-axis and one test on the x-axis, and then test the performance of one against the other. But part of what is used to calculate how good a test is what is called area under the curve, which wasn't given here, but the area under the curve, if it's more than 50%, it makes the test a better one, and the higher it goes, the better. So just to summarize why they gave the prevalence here is because if one is calculating negative and positive predictive value, they depend on the prevalence of the disease in that particular population. Thank you. I hope I've not added to the confusion. Thank you.
I hope I understand what you've said, Dr. Rukaya. Thank you so much. My issue was with this sensitivity and which one was a better screening tool than the other. And it was based on the higher specificity of the tests. Of why the answer was B was because of the higher specificity of that test compared to A. So if at a percentage of 98%, it has a higher definitely to be a better test than B will be a better test than A. So I hope I've not confused.
Yeah, better screening test. So why they chose B was
better test? That's the
it's
question.
a better screening test.
Why?
So it's a better screening test because at a high sensitivity. So B was a better screening test because at a higher sensitivity, it had a better specificity than A.
What does that mean?
So that means with sensitivity, like I defined before, sensitivity, when it is negative, it is unlikely for you to have the disease. So when it is negative, it is unlikely for you to have the disease. That means it rules out a lot of false negatives, sir.
So
also it has a higher specificity. That means it also has a better ruling. That means the better confirmatory test also than the
I think you have the idea. I think you're very correct. But 2 words.
Okay.
Be able to rule in those that have the disease and rule out those that does not have the disease.
Okay, sir.
That's the 2 words. Remember, we're talking about some group of patients that comes with STEMI, and they come with intermediate symptoms. Usually, they are the people that have chest pain. CHOP will just be between an intermediate range between 14 and 100. This group of people, if you do an angio for them, their coronary will be, some of them will be normal, while other people will be positive that may need stenting. So once they come at this intermediate risk, you're usually a bit confused. See whether you should take the cath lab, should not take that cath lab. So you need a test, like you have just said concerning the A, if I see very well, not very clear here. Is it A or B?
Let me zoom it in.
Yeah, okay, I've seen it now. B. That's able to rule out those that do not have STEMI, even though they have a trope between 14 and 100. Intermediate risk, that's what I mean. They're able to rule out those people so that those people will benefit from intervention. So you need a test that have high sensitivity so that they can rule in, confirm like the word you use. but usually they like to use the word rule in. Then you need a test that's with high specificity, that is able to rule out, remove the people that do not have the disease. Remember that specificity means that the tests become negative when there is no disease. Sensitivity, the tests become positive when there is disease. So that's the concept of this kind of thing, ROC curve and all the rest. And things like CTPA become very important as a rule-out test. CTPA really, is this CTPA I mean to say? I'm referring to CT angiogram, not CTPA. CT coronary angiogram for people that have intermediate STEMI. So it's a good test for ruling out. So once it's negative, it can almost 90% tells you that the patient do not have the disease. But it's not a good test for ruling in. Okay, so better test for ruling in will be things like the PET or cardiac MRI. So usually once you see these patients that are intermediate risk, you're asking yourself, do they have the disease or they don't have the disease? Especially in a place like the UK, they're very conservative in their resources. So they want to do a test that will rule out a patient where they don't want to spend some money. But places like US, where they want to do everything, they are much more aggressive to do anything they want to do. So I brought out that example as a follow-up with a discussion we had earlier, just to bridge the gap. Good.
Thank you so much, sir.
Thank you.
Thank
All
you,
right,
sir.
hello. Thank you very much. Sorry, can I just say something?
Go ahead.
Okay. Another dimension again that we should look at it is using the positive predictive value and negative predictive values. Okay, because these two derivatives, they are actually gotten using, if you look at your slides that she projected earlier, they are actually gotten using those 2x2 tables where we got false positive, true positive, and false negative, true negative. So it's actually a probability. For instance, now let's take positive predictive value is a probability of the tests to be able to truly identify those that are positive. The negative predictive value is actually a probability of that test to be able to identify for you those that are truly negative. Okay, so best statistical parameter to use if you want to determine if this test is appropriate for ruling in or ruling out, look at, if for ruling in, look at the test that has a high positive predictive value. For ruling out, look out for a test that has a high negative predictive value. What it means is that if a test has a high positive predictive value, and it tells you that you conducted the test, and it shows you that it's positive, there's a very high likelihood that it is truly positive. So it helps you to rule in. If you use a test with a high negative predictive value, and it shows you that this is negative, what it means is that the probability that that test is truly negative is very, very high. So that's the point I just want to add. Thank you.
So which also brings us to the fact that if you are defining your specificity, if you remember that in specificity, you are looking at the true negative, okay, all divided by true negative and the false positive. True negative, that those are really true negative, all divided by true negative plus false positive. So once your false positive is larger is going to affect the specificity. Once your false positive is smaller, you're going to have a better specificity. Anyway, if these statistical terms are confusing here and there, just have it in your mind. Sensitivity help you to confirm. Sorry, sensitivity help you to confirm. Specificity help you to, remove patients. So that this false predictive, predictive is so whichever way you can understand it, just make sure you understand it. Thank you.
Thank you, sir. Thank you, sir. Can this be an example? Like, for example, a patient who has pulmonary embolism, and then we do a D dimer. The D dimer is elevated, and that's sensitive. And then we have other causes of elevated D dimer, and then we go further to do maybe a CT pulmonary angiography, and it says it is negative. So does that mean that the CT pulmonary angiography is highly specific, and the D dimer is highly sensitive? Meaning that the D dimer was positive, saying that this patient may have PE, but there are other causes of PE. But the CT pulmonary angiography is highly specific. So once it is not there, that patient doesn't have pulmonary embolism. Is that a good example?
So that's why we use CTPA to rule out pulmonary embolism.
Okay. So could that be a highly specific test? Like
example.
Ruling out that this patient doesn't have it.
Yes, CTPA is
okay.
That's why it's the gold standard.
Okay.
So
that's an example.
Yeah, if it's negative, it's almost 100% telling you that it doesn't have pulmonary embolism. Okay, but D dimer, if it's positive, you know that apart from pulmonary embolism, there are other things that can give you a positive D dimer. So it's not a very good sensitive test. But again, D dimer is a bit specific because if it's high, it is suggestive. But also remember that you compare tests. Compare D dimer to CTPA because the false positive in D dimer is high. So that reduces specificity compared to CTPA.
Okay, sir. Thank you, sir.
If these statistical terms are confusing you, use terms that you are familiar with, rule in, rule out.
Okay.
Make life easy sometimes.
Okay, sir. Thank you.
I think Precious, thank you so much. You've done an excellent job. You know, statistics, they say you can't learn it in one day. You have to do it over and over. So that we don't waste so much time. I don't know if she can continue if there are no questions. Precious, thank you so much. You went very, very detailed. Please share us your very powerful slide.
So my last question, thankfully, is 130. So it reads as follows. For each clinical scenario, select the appropriate ECG from those provided in figure 1.29. So these are the ECG. So there's A, B, C, and D. So the task ahead of me is 130, which it reads a 49-year-old man with chronic renal failure and progressive fatigue. So when we're talking about renal fatigue, when we're talking about renal failure, the most important thing that comes to mind when it comes to ECG and renal failure, we're thinking about the patient has anemia, hyperkalemia, electrolyte derangements. So most likely we're looking for an ECG that has some electrolyte derangements. So when we look at the first, that's A, because I'll be running through some of the ECGs quickly before the next presenter so that you can know how I came to my conclusion of which ECG it was. So in the first ECG, I could see here.
Sorry, ma. There is a request that you should zoom in the pictures.
Oh, okay. Please, I will do that. Apologies, please.
Are we good? Dr. Precious, please hold on, please. Other option, you can, if you are using your phone, you can tap on it twice. It will zoom itself.
All right. I'm using my laptop, so so yeah. Is this fine, Chiefs?
It's fine. But In case it's not zoomed for you well, you can tap on the screen twice. It will zoom it in if you're using your phone.
All right. Thank you, Chief. So, all right. So the first ECG, what jumps out at me in this first ECG is that obviously there's tachycardia, but I think what's prominent here is just the slight ST elevation that is widespread in this ECG. That's what tachycardia is slight. It's very slight ST elevation in this ECG that is in A. Then B, what I can see here is something that looks like, we can see all these pseudo RSR that look like a right bundle branch block, but also looks like right ventricular hypertrophy in this patient. So I don't think that's in keeping with a patient that has a renal impairment. Quickly. All right. So here, obviously, we can see a block here. Obviously, in this, we can see bradycardia, which is very obvious here. We can see a 2-to-1 block here. Nothing that I can say is in keeping with my patient that has chronic renal failure. But when you look at this ECG, what jumps out at you at D is this T waves here. These peak T waves. And when we're talking about peak T waves, we all know some of the causes of peak T waves, which will include hyperkalemia, of which I said that in a patient that has renal impairment, what we should be looking for most likely ECG changes that will be jumping at you in their ECG will most likely be from electrolyte derangement. And from this ECG, I can see peak T wave, which makes me think of hyperkalemia. So what are the changes that you see in ECG on hyperkalemia besides peak T waves? You can see a flattened P wave, which is not here. You can also see a prolonged PR interval, which is not also here. Some other changes you can see on this ECG. 3, no. So it's mostly the T wave, the peaked T waves that you can see that are not in proportion with the QRS. And besides, there is poor R wave progression in this patient, which I don't know whether that's going to be part of. So obviously, there's going to be some cardiac pathology going on with this patient. So it's mostly the T waves that are here. So I'm going to think that this ECG belongs to my patient that has chronic renal failure, that has hyperkalemia because of some of the changes I have seen based on the T wave here. And I think that will be my last question, and I'll be handing over to the next presenter. Thank you, everyone, for your time and your patience.
Okay, thank you so much. I think, can you please just zoom in a little into the last ECG tracing?
No, I'm zoomed in.
Okay. Okay, so now let's look at okay. Okay, no problem. You can flip. Don't worry, go back. No problem. I've seen what I wanted to see.
Okay, tell us what you wanted to see now so that we can know what you're trying to see.
You know, for LVH, normally we say S in V1 and then array in V5 greater than or equal to 35. So if you look at the ECG tracing, you look at the S wave on V1 and then the arrow wave on V5 is about 36, about that. So it's also showing that the patient has a background LVH, which could be seen in a patient with chronic renal disease, maybe due to hypertension that has not affected the heart, aside this electrolytemia that can occur in this patient. I don't know. Yeah, that's like an additional thing. Then the QT, can we look at the QT interval? QT interval.
Okay, it should be, we need to calculate the rate. This should be, let me go zoom in. Sorry, let me zoom in properly.
Okay.
If we take this should be 5, 1, 2, 3, 4, 5.
So it's shortened.
200. So it's slightly shortened, but
yeah, it's shortened.
Yeah.
Shortened, of which we can see in hyperkalemia.
Yeah.
Yeah.
This is
So
400. This is 400. Is it? 200, 400. Then when you calculate it with rate, that's short.
Shortened.
That's
All
short.
right, thank you. Thank you so much.
Thank you.
All right, so I'm supposed to be the next presenter.
Do you need to share, or do you want to go ahead and share yourself?
Okay, let me share myself. I pray my network will be stable. I hope so. All right, thank you. Oh, can you imagine? Okay. Are you seeing my screen? Hello?
Yes,
You're seeing my screen, right?
Yes.
Okay. Okay. Okay, so 131, she has already done 130. So 131 says a 37-year-old man with a recent viral syndrome and sharp anterior chest pain that worsens when he changes position. So basically, this is just a patient with an acute viral pericarditis evidenced by chest pain worsened by change in position, of which it is worse when patients lie down due to the parietal and the visceral pericardium gliding against each other. And again, it's also worse on inspiration because the parietal and the visceral pericardium are also gliding against each other, knowing at the back of our minds that there's some form of inflammation ongoing. So there's usually pain in this patient with inspiration and then on lying down carditis. So before we go to the ECG tracing, I hope you're hearing me. Okay, so before we go to the ECG tracing, first and foremost, what do we see with a patient who has pericarditis? So normally what we see is they normally have a diffuse PRO segments, and then they also have a diffuse ST segment elevation. So from all the ECG tracings, the one that looks most likely with a patient that has acute viral pericarditis is the A tracing, ECG tracing. So I'm going to go down there so we can look at what exactly is ongoing there. Okay, so this is the A, ECG tracing. So basically, what we normally do, we actually use the TP segment as the isoelectric line to find out if this patient has an ST elevation or a PRO segment depression. So now look at what we call the TP segment. The TP segment is the segment from the end of the T wave down to the beginning of the P wave. We use it because at that point in time, the heart muscles are electrically silent. So it is most times not elevated nor depressed. So that's the isoelectric line we actually use to compare if this patient has an ST elevation or a PRO segment depression, which we see on pericarditis. So now let's compare. So this is the PRO segment, and this is the ST segment. So it is slightly higher. It's slightly higher than the TP segment. Let's draw an imaginary line down, and then we see that the ST segment is elevated, slightly elevated as compared to the TP segment. So this is it for lead 1. And then also we go to lead 2. This is the TP segment as well. So now let's compare. It's just slightly elevated. And then if you look, this is the the PRO segment. The PRO segment is depressed here as compared to the TP segment. You know, we're using the TP segment as the isoelectric line. So when we compare, we notice that the PRO segment is slightly depressed when you compare it to the isoelectric line, which we have at the back of our minds, that is the TP segment. And if you also go back to your lead one, you also see that the PRO segment is also slightly depressed when you compare it with the line, that's the TP segment. So yeah, so that is it for lead one. Lead two is supposed to be a diffuse, we're supposed to see a diffuse PRO segment depression and concave ST segment elevation. So this is another one again, lead three. So this is the TP segment. Remember, this is the T wave, and then this is the P wave. So let's compare. So you will notice that there's actually a depression. There's a depressed PRO segment, and you compare the isoelectric line. There's also the ST segment is slightly elevated. So if you compare these with every other lead, you notice that this patient has a diffused PRO segment depression and slightly elevated ST segments. And that is what is closest to every other ECG tracing that is there. So that's why I chose A as the clinical scenario of someone having an acute viral pericarditis. And also, as the previous speaker spoke, this patient is actually tachycardic, but it's not like it is specific for a patient with acute viral pericarditis. Maybe the septic form of the patient must have predisposed this patient to tachycardia. But basically what we see is a PRO segment depression and diffuse ST segment elevation, which we are seeing here on this ECG tracing. So the next question is 100. Yes. Okay. Yeah. Hello? Yeah, somebody's talking, please.
About AVR.
AVR. Okay, let me go back to the AVR. Okay. So what is it about AVR? Sorry, please. Can you just help me out?
What's the PR segment in the AVR like compared to your TP?
Let us see first now.
Okay, I thought she said she was not seeing it. Okay.
I'm not seeing, please. Dr. Kofi, please help me out with the AVR.
Check out the PR segment in the AVR compared to your TP segment you're comparing. Is it elevated?
It's elevated. Okay, the reverse is occurring. The reverse is occurring as compared to other leads. So the PRO segment is elevated in the AVR as compared to other leads that it is depressed.
So it's always important before you claim pericarditis.
Okay, that's true. Exempting the AVR. Thank you. Thank you. Thank you. Thank you, Chief. All right. So the next question. Okay, 132. So a 59-year-old man with severe lightheadedness. So basically, what should come to our minds is what are the causes of severe, that's cardiac causes of severe lightheadedness. So an atrial fibrillation can cause that because the heart is not contracting properly for the stroke volume to be adequate, that's indirectly affecting the cardiac output. So, you know, the brain actually requires about 25% of the cardiac output to be perfused. So because there's weak contraction, the cardiac output is affected, so perfusion to the brain is not adequate. So that can lead to lightheadedness, dizziness, pre-syncope, syncope, and all in patients. Like it can be one of the causes of lightheadedness in the patient, like a cardiac cause of lightheadedness. Then other causes of lightheadedness, because the reason why I'm actually thinking of this, so that when I get to the ECG tracing, I would have something on my mind, like what am I looking out for this option 132. Then other causes of lightheadedness, an AV block can cause cardiomyopathy because there's some form of systolic dysfunction. It can affect the ejection fraction. Perfusion to the brain is reduced, and then it can predispose this patient to severe lightheadedness, pre-syncope, and then syncope. So we will go down to the ECG tracing of that which I
It seems there is a network.
to what I think it is. So I'm going to the ECG.
So sorry, everyone. Our network is poor. Maybe we can give her a few seconds to see if she can come back. If not, and she already said that she will not be around tomorrow. So I don't know. Let's give her a few seconds, please. Thank you. Dr. Ozuki.
Yes, please.
I'm thinking
Okay, bye.
if Dr. Briggs, welcome back. She's back. It's not very clear,
Okay,
ma'am.
I don't know if somebody will help me share. Okay, I'm so sorry. My network has not been stable. It's fluctuating. Okay, let me go back to, oh God.
Should somebody help you share? You still want to share?
It's off again.
Oh.
You have to.
Dr. Ozuki. Please, over to you, sir. Dr. Ozuki.
All right. Do we give her a little time now, see if she comes back, or do we just start off like?
Okay.
Otherwise, let somebody help her share. And if the sharing is begin to take a toll on her network or something, otherwise I'll start from question number 91.
Okay. Dr. Sarah, please, can you kindly help us share the question? Thank you. Dr. Sarah, please. Thank you so much. Dr. Ozuki, I'm trying to put a call through to her, but I can't reach her. But I'll try again. So I don't know. Maybe you can continue in respect of time. Thank you.
All right. Good evening, everybody in the house. The presenter of questions number 91 to 100 is seem to be quite sick and unavailable to present this night. So we may be trying to present his section, even though we make effort to present it, and I pray that the whole house assists us to do that presentation so that we just clear with that and move on with other sections that are still outstanding.
Sorry, I'm back. I'm so sorry. Hello?
Thank you, Dr.
Hello?
Briggs.
Okay, so please, maybe someone will help me to share while I just read through. Okay.
Yeah, so I the sharing. You can continue, ma'am.
Okay. So I stopped at the AV block. That's the C option of the ECG tracing. Okay. So for the ECG tracing, if you look very carefully at this patient, we realize that we have multiple more of P waves than QRS complexes. Like, for example, here on the leads, you see if you notice, you see something that looks like a bifid kind of wave. So, but that is the first positive deflection is the T wave, while the one next to it is a P wave. So by right, after the P wave, we are supposed to have a QRS complex. So basically what this is telling us, meaning that the P wave is not dependent on the QRS complex, is not dependent on the P wave, because before the P wave, they're dependently from the QRS complex. And then looking at it, this is just an ECG patient has a complete heart block. So the cause of the dizziness, the lightheadedness for this patient was as a result of a complete AV block. So, but we can just remind ourselves of the different AV blocks, where the first AV block just basically tells us that a prolonged PRO interval and then without any disruption, meaning that the PRL interval is only prolonged. Degree AV block, we all know we have a Mobitz type 1 and Mobitz type 2. So for the Mobitz type 1, there's a progressive prolongation wave, and then the PRO interval, and then complex. Then what happens again for the Mobitz type 2 is that there's a constant prolongation, and then suddenly we don't see the P wave, and then there's a drop in the QRS complex. So that's the difference between the Mobitz type 1 and the Mobitz type 2. So the Mobitz type 1 just has a progressive prolonged PRO interval until a P wave is not conducted. And then the Mobitz 2, we have a constantly prolonged PR interval, and then a P wave is not conducted, but that's not what we are seeing. So what also the lightness? So the next question is okay. So the next question is number 133. So the question here is, a 38-year-old woman with perioral and peripheral cyanosis, digital as a child. So basically, this is just telling us that this is somebody who had a congenital heart disease. They said a history of cardiac surgery as a child. And then this patient is what is having perioral and then peripheral cyanosis, telling us that there's a background. There could be a shunt, meaning that there's a problem with the oxygenation of blood in the left side of the heart, which probably would be from a shunt which is present, whereby the deoxygenated blood in the right ventricle is now combining, or is now mixing with the oxygenated blood and the lesion of the oxygenated blood. Hello? Oh, God, my network today. Hello?
Yes, we lost you for quite an interval. The network was really
I don't know why today, why my network is
serious. So.
I'm so sorry. I'm so sorry.
Dr. Florence, sorry everyone. Our network is really poor tonight and it seems to be quite unstable. I don't know if we agree. I'll try and chat her up. Maybe we should continue the questions with somebody that Dr. Florence, welcome back. Your network is quite unstable and is really dragging. I can't really pick up the explanation I'm trying to make. I will just make a suggestion to us all, if it's possible that.
Yeah. Okay. So if it interrupts.
Hello.
I'm here. I'm with you.
Yes, it's
I'm
really,
with
really,
you.
it's really dragging, ma. So I can't really pick what we are trying to explain. It goes on and off. And I don't know whether it's quite stable now that we can continue, or if we might have to. I don't know. Do you have another network or something? I don't know.
Yeah, I'm trying to use my husband's device.
Okay.
But are you hearing me now?
Yes, right now we can hear you. I can hear you rather.
Okay, whether I'll just continue and be fast as well.
Yes.
Okay.
Thank you. We can hear you right now with this particular network.
Okay. All right. Okay. Can we go to the ECG tracing? I just want to be fast. The B.
Thank you.
The B ECG tracing.
Sorry, just a minute. My system kind of froze.
Okay, so let me just be talking while he's trying to get his system sorted out. So basically, in left to right shunt, what happens is that there's a backward flow of blood into the pulmonary vasculature, which can predispose this patient to pulmonary hypertension. So basically, what we are looking out for in this patient is a long pathology ongoing in this patient, because this patient is having an issue with saturation. So going into the ECG, what we should have at the back of our minds is that this patient has a congenital heart disease, of which in quotes, the patient has a left to right shunt causing the cyanosis in this patient. And then probably this patient must have come down maybe with pulmonary hypertension. So going to the ECG tracing, we'll look out for ECG tracings of features suggestive of right-sided pathology. So looking at all the ECG tracings, the B ECG tracing was what actually took my mind more to the underlying question. Okay, thank you so much. Thank you. Okay, so first and foremost, looking at this patient, the axis deviation. So I actually used an AVF. One actually has a negative deflection, while AVF is actually equal. It seems equal. So I compared it with 1 and 3, and then there was a negative deflection on lead 1, and then a positive deflection on lead 3, which suggested this patient has a right axis deviation. Then also looking at the ECG of this patient, if you compare, let's look at the V6 of this patient. if you compare the S wave with the arrow wave, like we are doing an S arrow wave ratio, the S over arrow wave ratio is actually greater than 1 on V6. And that is one of the features suggestive of right ventricular hypertrophy, which we see in left to right shunt, because the pressure in the left side of the heart, which is higher, is now equal with that of the right, because there's now shunting of blood from the left to the right. So the pressure in the right is now high, thereby leading to a right ventricular hypertrophy in this patient. So another pathology I noticed on this ECG tracing was the arrow S arrow pattern, which is the M pattern. The M pattern, that's M pattern Hello, sir. Hello, sir.
Sorry, that V6, you meant R to S less than ratio less than 1 or greater than 1.
R to S. Okay. R to S. Okay. No, S Q R S. S to R ratio greater than 1. S to R ratio greater than 1 on V6. Hello, sir. Okay. Hello, sir. Oh, hello, sir. Hello. Are you hearing me?
We can hear you, Dr.
Okay. Okay, so what he said, R to S ratio is actually less than 1. So there it's not suggestive of a right ventricular hypertrophy. So for V1, we actually have an arrow S arrow pattern. That's like the M wave. We are seeing an M wave on V1. And then on V6, we are seeing a W wave, but this is an incomplete right bundle branch block because the QRS complex is not prolonged. So basically the pathologies that I can actually see here on this ECG tracing is right axis deviation, arrow S arrow pattern on V1. And then the QRS duration is actually not broad. So this patient has an incomplete right bundle branch block with a right axis deviation. And then this is also telling us that this patient has a delayed conduction on the right ventricle. So it's telling us that the patient has a pulmonary pathology ongoing, which is what is responsible for the cyanosis in this patient, meaning that this patient is having probably pulmonary hypertension, which is one of the causes of our right axis deviation. So that is my own thinking for this particular patient with this ECG tracing. So from all the ECG tracings, this was what I think went the most with the clinical scenario, but I think I can be helped out here if I'm not right or contributions. Thank you.
I think you are right.
Okay.
I think you're right. The only thing we should look out for too is this AVR. AVR is supposed to be a negative deflection because of the right strain. So we can see a positive deflection on AVR too. So that is also important in the diagnosis. Thank you.
Then also the arrow wave progression on V1 to V6 is actually poor because as it progresses, the arrow wave is supposed to, the amplitude is supposed to increase. But when it got to, it increased to V2, but at V3, it reduced as compared to V2. And then at V4, it became, the amplitude became, that's height-wise, it became shorter than V3. So this patient has a poor arrow wave progression, which is diagnostic of a patient who has a prior anterior myocardial infarction. So these are the pathologies I'm seeing here in this patient. And this looks most likely like the picture of the clinical scenario that was painted in the question. So, okay, thank you. Okay, so the next question.
Yeah, the hand of Dr. Itibo's hand is raised.
Okay.
Yes, good evening all.
Yeah, good evening.
I just want to add that if we look at the leads V4 to V6, especially on V5 and V6, The S wave is more prominent than the arrow wave.
Okay.
And so when we do that arrow over S or S over arrow, if we do arrow over S, we are going to have less than 1.
Yes,
and when you have persistent S wave that is prominent on V5, V6, so the S wave is supposed to disappear. Arrow wave is supposed to be more than S wave. So this actually indicates that the patient may be having a right ventricular hypertrophy. That's my own understanding. I don't know. I need to be clarified.
I think you're making a lot of sense. Thank you. So, any other contributions? Or I should go ahead? Okay, so 134. Okay, the question is 134. A 62-year-old man who sustained a myocardial infarction 1 month ago. So this is his echocardiographic picture. So basically, they want us to cite the pathologies seen in this patient. So this is actually an apical 4-chamber. This is actually a transthoracic echocardiogram, an apical 4-chamber view, where we would see the 4 chambers, and then we will see the mitral and the tricuspid valve. So basically, when we do an eyeballing on this patient, we will see a hyperechoic mass in the left ventricle, which is actually narrows down to a thrombus. You know, the acute thrombus normally is hypoechoic because there's still flow of blood there's flow of blood inside too. So when it is acute, it is hypoechoic. But when the thrombus has been there for some time, when it is chronic, it becomes hyperechoic because there's no free flow of blood inside too. So this is hyperechoic, which is significant, which denotes a thrombus. Then doing an eyeballing, the left ventricle looks bigger than the right ventricle. Then also, if we look at the lateral wall of the left ventricle, we are seeing a space. Initially, I thought it was a pericardial effusion, but my second thought, I was like, pericardial effusion, you find it, I don't know if I'm wrong, most times you find it round, it goes round the circumference. But for this particular space that I'm seeing here, it seems like it's just at the lateral wall of the left ventricle, where it seems as if the wall of the left ventricle is separated, where I'm thinking it may be a left ventricular aneurysm, or it could also be pericardial effusion, but because depending on how the position of the heart is, it's tilted towards the left, and then fluid gravitates towards the left. So it may be a pericardial effusion or a left ventricular aneurysm. So I want contributions for this. Then also as I made mention earlier on, that the left ventricle is dilated, there's a thrombus, and then I'm also thinking there's a left ventricular aneurysm or a pericardial effusion. So I will need the house to please help me out if this is a pericardial effusion or a left ventricular aneurysm. Because pericardial effusion, I'm thinking I'll see it goes round the circumference, but this is just at the left ventricular wall, the lateral wall of the left ventricle. So please, I'll need contributions, suggestions about this particular picture. Thank you.
Okay. Well done,
good
Dr.
evening,
P.
everybody. Okay.
No,
sorry.
sorry. Well done. Sorry,
Thank
please.
you.
I don't know whether it's my eyes. I think is the intra-atrial septum okay? I don't know whether it's the image, as if there is a shunt there. I don't know whether it's just my eyes.
It looks as if it looks as if there's a septum it looks as if there's an atrial septal defect, but a color was not passed across it. So it could be from how the imaging was taken. So, but that is what we are seeing. So it could be a defect on the atrial septum. It could be a defect, but it would be specific if color Doppler was passed across that.
Okay. Then concerning the space, I feel is an effusion, because small effusion gravitates towards the LV free wall. So I am thinking it's an effusion. That's what I think.
Okay.
Thank you.
Okay, thank you. Thank you.
Okay, good evening. I wanted to add that the normal shape of the left ventricle is actually like a bullet. So if you look at the apical area where the thrombus is, it is wide, it is dilated, and that is actually the aneurysm. Okay, that's sort of outpouching is actually the aneurysm. Okay, and what is there outside that echo-free space, I think is pericardial effusion. Okay, the other one in the septum, personally, I think is echo dropout. Is usually common in 4-chamber view. Okay, it's not, and because looking at the position of the septum, I think it's just based on the way it was positioned, it's just an echo dropout. Thank you very much. Thank you for what you said about the thrombus. It's very enlightening. Thank you.
Okay, thank you so much. But can someone please, the person sharing the screen, can you please point where exactly he said is an aneurysm and an effusion? Because I've still not gotten it. So sorry. Okay, so that is what
Okay,
exactly?
that's effusion. That's effusion. To me, that's effusion.
Okay.
It's a loculated effusion. Then that's the
Okay,
aneurysm.
thank you.
Yes.
Oh, thank you so much. I appreciate it. Thank you. Okay, so the next question, 135. A 33-year-old woman with an early systolic click. So this is a picture that has been given to us about this lady. So this is a parasternal short axis view. And parasternal short axis view actually shows us all the chambers except the left ventricle. Then also it shows us all the valves except the mitral valve. It doesn't show us the mitral, sorry, except the mitral valve. It actually shows us the pulmonary valve, the tricuspid valve, and then the aortic valve. So the aortic valve has this sign we call the Mercedes-Benz sign, just like a Mercedes-Benz, how the sign is. But looking at this picture of this patient, the Mercedes-Benz sign is actually absent. So what I'm seeing is as if I'm seeing two cups, like as if I'm seeing the lateral cups and the non-coronary. I stand to be corrected, but the defect is actually at, if you look at the arrow up there, the defect up there, if you notice the joining where you have the two valves, as in like is a bi-leaflet. It's supposed to be tri-leaflet, but it's bi-leaflet. So the joining, the first joining is at 10 o'clock. 10 o'clock meaning that it's close to 12 o'clock, like you're drawing imaginary clock. So that joining where the two leaflets actually meet, that's the 10 o'clock. And on the other end, that's the 4 o'clock, like soon after 3 o'clock, if you're drawing an imaginary clock. So this is actually not a tricuspid valve, which is not a tri-leaflet. This is bi-leaflet, meaning that this patient actually has a congenital bicuspid valve. So that's what this patient has. So that is the congenital defect this patient has. So I think that is the pathology on this view that we are seeing. It's not tri-leaflets, but it's bi-leaflets. So I don't know if we have any other contributions to give as regards this particular patient. So that's the only pathology I can see using this view. So I don't know if there's any contribution we can give. So the normal Mercedes-Benz sign is absent. So that is a bileaflet, and then making it a bicuspid aortic valve, which can be seen in some collagen disorders like Marfan's and Landalas and all. So that is what I'm thinking here. So I don't know if there's any contribution, any addition to this particular question. Okay, so if
I
there's
just
none, I
wanted
go
to, no, I just wanted to add that it's usually congenital. I think that's
Okay. Okay.
so it's likely that the person was born with it and will likely develop aortic stenosis later.
Okay. 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 Thank you. Okay. So the next question.
And maybe I should
which
just
is,
make the comment on. Thank you, Dr. Florence, Dr. Briggs. The labeling that you were talking about. So there are two valves here, just like you have said. So the one close to the right ventricular outflow tract will be the right coronary corpus.
Okay.
The one close to the that we're saying RA, this one close to the RA will be the non-coronary corpus. So where we are supposed to have the left coronary corpus is what is absent. That one should be close to the LA. So your landmarks usually should be that the very close to the right ventricular outflow tract, you normally should have the right corpus. Then the left corpus will be down where the LA is. Then the non-coronary will be the one close to the RA on this view.
Okay. Okay.
Yes, so you will not see the non-coronary corpus if you are looking at the long axis view.
Okay.
All
Thank
right.
you.
Thank you.
Thank you so much. I appreciate it. All right. Okay. So the next question is 136. A 26-year-old man with a loud asystematic systolic murmur. So this is the echocardiographic picture. Probably this patient has a pansystolic murmur, which we can see in ventricular septal defect. You can see in mitral regurgitation. We can see in tricuspid regurgitation. So this is a parasternal long axis view where we can see the left ventricle is well labeled, the left atrium, the aortic valve, the mitral valve, and then high up, we have the right ventricle. If you notice, color Doppler was actually passed across. So that is where they are actually taking us to like the pathology. There's an obvious pathology. So that is the ventricular septum. That's the septum that divides the right ventricle from the left ventricle. And there shouldn't be a communication. If color Doppler is passed across that, there shouldn't be a communication. So there's an obvious defect on the ventricular septum. So this is a ventricular septal defect seen in this patient on a parasternal long axis view. And then this patient has a left to right ventricular shunt. So that is what this patient has, a ventricular septal defect. So that's a regurgitant jet scene passing through the defects on the ventricular septum. So this is the ventricular septal defect that this patient has. I don't know if there's any contributions, any other thing that anyone wants to add to this. Okay, so I move over to the next question. 137. A tall, thin, 31-year-old woman with diastolic murmur. So they are showing us a parasternal long axis view of a patient, and then we can see a cursor showing us where the aortic opening is, and the diameter there, if you see above there, is actually 4.2 centimeter, and then it's the normal diameter is supposed to be between 2.1 to 4. So when it is greater than 4 centimeters, the aortic opening is actually dilated. That the aortic root is dilated. And from the history, they said a tall, thin, 31-year-old woman. So that tall, thin, 31-year-old woman is actually taking us to a collagen defect, which is maybe secondary to Marfan's syndrome. Although we also have situations like the Ehlers-Danlos, but in Ehlers-Danlos, what happens is that the patient will present with hyperflexibility. And then the patient will also present with easy bruising, but they didn't give us the history of hyperflexibility. If they had given us a picture of hyperflexibility, it would have been aortic dilatation secondary to Ehlers-Danlos. So depending on what clinical scenario that is being given to us, then we will now say, okay, that is the cause of the pathology seen on this particular view given to us. So that is what I can say. Then other causes of aortic dilatation, we have degenerative causes. We also have causes from atherosclerosis, inflammatory causes like Takayasu, heart disease, Behçet disease, infections like syphilis, infections like septicemia generally can also lead to that. Endocarditis can predispose a patient to having aortic dilatation, and also trauma. So, but in this case, it's secondary to Marfan's because of the TT, tall, thin, 31-year-old woman. Okay, so the next question is 138. A 59-year-old woman.
Dr.
Yes.
Sorry. Please, the diastolic murmur, I think there's an AR, even though they didn't add the color flow. I think the diastolic murmur they're talking about there, I think there's dilatation with an AR. That's why they told us that she has a diastolic murmur.
Okay.
Thank you.
Okay, that's true. Because the valves will not be coapting properly because of how dilated the aortic opening is. So the valves will not coapt properly, and then blood, there'll be a backflow of blood. Yes, thank you so much. So there's actually complicated with aortic regurgitation. So this is the patient who has aortic dilatation complicated with aortic regurgitation secondary to Marfan's syndrome. Thank you so much. Okay, so 138. So the question says, a 59-year-old woman with a systolic murmur. So this is an apical 4-chamber view, and color Doppler was actually passed across the mitral valve. And then if we look closely, the regurgitant jet is actually massive. So we can actually check the severity of mitral regurgitation, either using the regurgitant fraction, where we would actually take out the portion of the mosaic pattern. Is a mosaic pattern that is actually the regurgitant jet. We would actually take the portion of, we'll take the area of the regurgitant jet, and then take the total area of the left atrium. And then the fraction you get will now tell us if this patient has a mild, moderate, or severe regurgitation. Although there are other parameters we can actually use, other methods we can actually use. So for this case, if the regurgitant fraction is actually less than 30, it's a mild mitral regurgitation. If it is between 30 to 49, it's actually a moderate. If it is severe, it's greater than 50. But with eyeballing, looking at it, it's actually getting to the end, the end of the left atrium, telling us that this patient actually has a severe mitral regurgitation. Then we can also use vena contracta, where at systole, you actually know at systole, what happens is that we'll do it at diastole. In diastole, the valves actually collapse. So because there's a defect to the valve, there will still be backflow, there will still be regurgitation ongoing. So what happens is that we will now measure the diameter at that valve, where at the point where the valve is supposed to collapse. We'll measure the diameter, that's the vena contracta. So what happens is that if the diameter is less than 0.3, this patient has a mild mitral regurgitation. If it is 0.3 to 0.96, that is moderate. And then if it is greater than if it's greater than or equals 0.7, this patient has a severe mitral regurgitation. But using eyeballing, this patient actually has a severe mitral regurgitation. So that's what I can say for this particular apical four-chamber view of this patient. So the systolic murmur is actually coming from mitral regurgitation. Okay, then for the B view is actually a Doppler. Doppler was actually passed across a pulse Doppler was actually passed across the valve. And normally what happens is that the left atrium, or how do I explain it? When we want to measure the EA ratio, we actually get it for the tricuspid or mitral, we get it above the baseline. But anything below, if you notice, we are seeing a regurgitant jet below the baseline. So any regurgitant jet for mitral and tricuspid regurgitation below the baseline is actually called a tricuspid, depending on where the Doppler was passed. Like this is a mitral. So this is a mitral regurgitation on pulse Doppler. But if this pulse Doppler was passed across a pulmonary valve or an aortic valve, the regurgitation is said to be seen above the baseline because there's a backward flow. So basically what this is trying to tell us is that there's actually a backward flow of blood back into the pulmonary vein. When there's regurgitation, what happens is that blood moves from the left, goes backwards. The left ventricle gets into the left atrium and then gets back into the pulmonary vein, because the pulmonary vein is what sends the blood into the left atrium. So it's showing us that there's a backward flow of blood from the left atrium into the pulmonary vein. So that's what basically is trying to say on pulse Doppler. It's still telling us that this patient has a mitral regurgitation. And also when a color Doppler was done, it's also showing us that this patient has mitral regurgitation, looking at the mitral regurgitant jet in this patient. So I don't know if anybody has an additional thing to say, any correction about this particular question. Okay, so if no, okay, I go to the next question, 139. So from 139,
yes.
because okay.
Hello.
Yes, I can go on.
Yeah, so the second panel is actually a sample through the pulmonary vein, like you mentioned. So this is something you see with severe mitral regurgitation. You get systolic flow reversal in the pulmonary vein. So that's what this is showing you. So you see they've marked the systole and diastole. So the first dotted line, you see that was in diastole. Okay, the middle one is in systole. Okay, so normally when you put a Doppler sample in the pulmonary vein, the flow should be going downwards. That is showing you the normal flow into the left atrium. But then in systole, when you have severe regurgitation, that flow is reversed. Instead of blood flowing into the atrium, it's now flowing, the regurgitant blood is flowing from the atrium into the pulmonary vein. So that is systolic vein and pulmonary, systolic reversal of pulmonary venous flow. And it's seen as a sign of severe mitral regurgitation.
Okay, thank you so much. Thank you.
To look at it on the image, just look at where the cursor is. You can see that is at the pulmonary vein. That's up there. Yes, thank you. Yes, you can see that is in the pulmonary vein. Thank you, Dr. Conte.
Okay, thank you. Okay. So the next question is Doppler tissue imaging in a 54-year-old man with multiple myeloma, exertional dyspnea, and peripheral edema. So this is actually a 4-chamber view where a Doppler tissue imaging was actually done on the lateral mitral annulus. So it actually gave us a lateral E prime velocity of 7.31 centimeter per second. So anything less than 8 is suggestive that this patient has a diastolic dysfunction, a left ventricular diastolic dysfunction. So now in the picture here they give to us, they said this patient has multiple myeloma. So now we're now trying to find out what exactly is causing this diastolic dysfunction in this patient. So this could be as a result of cardiac amyloidosis. And the type I'm thinking of is maybe the AL, the light chain cardiac amyloidosis, though the trans-tyrosine cardiac amyloidosis is commoner, but I'm thinking of a light chain cardiac amyloidosis causing the diastolic dysfunction in this patient based on the history of multiple myeloma given to us in this clinical scenario. I don't know if we have any questions.
Thank you, Dr. Briggs. I just want to mention that with diastolic dysfunction, when you're measuring your Doppler measurements at the lateral, I think the highest should be 10. Anything less than 10 is the septal that is 8. I could be wrong.
Some books say 10 for the lateral. Yes, some say 8 there for the septal. Some say 7. So I don't even know which to work with.
Septal is 7. Lateral is 10.
10, I know for yes. Okay, septal is 7. Okay.
Yes.
Okay, please, sorry, please, what's your reference? I apologize because
that's the guideline you mentioned. 4 criteria. Annular E velocity, septal is 7, lateral is 10. Then for E over E prime is greater than 14.
Less than, it has to be less than 14.
E over E prime is 14. Then LAV is 30, greater than 34, I think.
Yeah.
Yes. Then the TR peak velocity should be around 2.8. That's the diastolic dysfunction.
Diastolic dysfunction measurements when you're trying to evaluate.
Those are the yes.
Yeah. All right. It's quite confusing. All right. Thank you so much.
Yeah, it could be. Thank you.
Thank you.
Okay, thank you. Thank you so much. I appreciate it. Thank you.
Yes.
Because
I understand you, Dr. Briggs. The when we do the normal, the usual grading before, it should not be greater than 8 for E over E prime velocity. That's the one we used to know before the recent guideline. That's average I'm putting at the septa, but that's E over E prime. Should be less than 8. Yes. Thank you.
Okay, thank you so much. Thank you for your contributions. Thank you. Okay, so the last question. A 44-year-old woman with an acute stroke. So, so this is a picture given to us about, it's actually about a bubble, they call it a bubble test. A bubble test is a test done to actually detect if a patient has patent foramen ovale. So, foramen ovale is said to have fused, it's said to have fused after, as in during birth or soon after birth, it should fuse, meaning that there should be no communication between the left atrium and the right atrium. So when it is patent, it now becomes a patent foramen ovale. So the bubble test is actually done to detect when a patient has a patent foramen ovale. So how this test is done is that saline is actually taken into the brachial vessel and then taken straight into the right atrium. So it's expected that the saline would going into the right side of the heart comes with bubbles. And these bubbles, the bubbles as the air is supposed to be absorbed when it gets into the lungs. From the right side of the heart, blood, everything goes into the lungs. From then it goes into the left side of the heart. So if after doing the bubble test, you see the bubbles in the left, we are not supposed to see the bubbles in the left side of the heart. If you see the bubbles in the left side of the heart, which is the next picture, know that this patient has a patent foramen ovale, because it's expected that the bubble should be absorbed by the lungs and then should not be seen in the left atrium. So looking at the next picture is showing that we have bubbles in the left chamber of the heart, telling us that this patient actually has a patent foramen ovale. So this is a picture showing us that the patient has foramen ovale, patent foramen ovale, doing a bubble test. Then secondly, if you look closely at the atrial septum, you notice a bulging towards the left atrium. So that is actually what we call an atrial septal aneurysm. And then we have different gradings of atrial septal aneurysm. We have the one arrow, meaning that it bulges during systole, it bulges towards the right atrium. That's during systole. You notice that the bulge goes just into the right atrium. Then we have 2L. 2L means that it bulges into the left atrium, of which this is looking like that. But when you put it on motion, you get to know whether it will just bulge into the left atrium and then go back into the right atrium, which is called the 4L arrow. So we have the one arrow, meaning that during systole, the bulging just goes into the right atrium. We have 2L, meaning that during systole, the bulging goes into the left atrium. And then we have 3RL, meaning that during systole, it bulges into the right and then swings back into the left. And then we have 4LR, it bulges into, moves into the left atrium and then goes back into the right atrium. And then for 5, it's just static. It's seen both in the right atrium and in the left atrium. There's no movement, it's just there, even with or without systole. So for this, since it's not in motion, maybe we can actually, it's bulging into the left atrium, since it's static, maybe we can actually work with 2L, but on motion, we can actually tell if it is moving into the left atrium and then going back into the right atrium, whichever way. So this is a patient who has patent foramen ovale and atrial septal aneurysm. So that is what I can figure out from this particular picture. Thank you so much. I don't know if we have contributions or suggestions. I think I'm done with my part.
Thank you very much. Oh, what I wanted to add, thank you very much for your very clear explanations. Okay, I just wanted to add that it's agitated saline that is used, not just saline, because the saline has to be agitated. If not, you won't see the bubbles. And how it's done is that, in addition to what you have said, you actually need a 3-way stopcock. Okay, so the stopcock is put on the peripheral vein with 2, maybe either 10 ml or 5 ml syringes. Okay, that way you can now agitate the saline one after the other, something like that. You just push it in and push it out. Okay, before you now push it in. Thank you so much. That was just what I wanted to add to what you said.
Okay, thank you. I appreciate it. Thank you. So I'm done with my parts. Thank you.
Thank you very much, Dr. Briggs.
Thank you.
Thank you, Dr. Briggs. Thank you so much.
So, Uzoke, I thought you were going to speak on behalf of the class. Are we taking another person? It's almost 11 or 10:11. Are they Andrews now around?
It's 11 o'clock. If the class will permit, I can take the one that's 91 to 100. Otherwise, we can just rest and start again tomorrow. We're able to take only 30 today.
That's we can, since we are doing Monday to Friday,
guys to start tomorrow, but it's up to you guys. So tomorrow.
Please start tomorrow.
All right. So bye bye.
Okay, thank you very much. I think I want to use this period to plead with the whole class. We may be getting across with some of us that may assist us in a few other things in the class. Maybe sometime tomorrow. I wish the other more senior members of the class maybe help us conclude the class, make some statements. Chief, quickly, Professor Oladimeji.
I think Okuku has concluded the class. We can have good night rest. See you tomorrow.
All right, sir. All right, sir. Thank you very much, sir.
Yeah.
Good night, everybody.